Hello, everybody, and thank you so much for joining us once again for another one of our wonderful educational seminars. Today we have the delightful Dr. Ashwani Garg, who is a consultant psychiatrist with more than 15 years experience, and he specialises in psychotherapy, autism, ADHD, advanced nutritional therapy, mood and anxiety disorders, and a psychotherapy called rational emotive behaviour therapy, as well as psychodynamic psychotherapy. He's a well-rounded guy. He writes an outstanding report and has a lovely rapport with the clients when he does an assessment. We are very proud to have him along with us today. Without further ado, I will hand over to you. Everybody, please keep yourself on mute so that noise from your home or workplace doesn't interrupt the recording. There will be time to ask questions at the end of the session. Thank you so much, and over to you, Dr. Garg.
Thank you, Michelle, for the introduction and also giving me opportunity to speak about mental health. It is a very gray area, and medical legal space is more challenging than normal treatment, because in medical legal space you need black and white answers, and unfortunately mental health is not black and white. It can be very challenging to deal with medical legal cases. So today I would like to share my experience. I started doing medical legal work in 2014, and on another day I counted, I've done more than 1,000 reports. So I would just like to share what I've seen in space and what kind of challenges I had and how I negotiated them. So I'm just going to share my slides. All right, so today we are talking about challenges and solutions in motor vehicle or work accidents in psychiatric IMEs. So the two questions you would have come very often, or at least I have been asked very often: how come a minor accident led to a permanent impairment? And also, is this client malingering or exaggerating their symptoms? That's a very common questions which goes through people's mind when they are dealing with medical legal cases in mental health. So I'll share some cases which I've seen recently, which will highlight these issues. The first one is, this is a young Asian overseas student who was walking in a shopping center, and a bike comes and bike was about to park and hits her at the speed of 5 km/h. And she falls down, but somebody holds her. She doesn't falls on the ground, develops some minor injuries. So she was fine for a couple of days, and after that she develops some pain in her leg. She goes to her GP. GP asks her to get some x-rays. She didn't have medical insurance, so she goes to a hospital, asks how much it's going to cost her, and she panics because she didn't have much money, and develops anxiety. And she was about to give her exams, so she fails in exam, which leads to big panic, because her parents were supporting her financially. They really stressed themselves to fund her studies, and now she doesn't want to tell them that she has failed her exam. They have to pay for another year, and that's how she develops quite severe depression. So it was a small incident, but the other factors have played big role. So the other case is, this is a 35-year-old man who had a major accident, I would say. But he developed psychosis. Psychosis is a big mental illness. It usually doesn't happen with motor vehicle accident. But what happened with him, he was driving his car to work, and another car jumps in front of his car, and he just fails to stop, rear ends the other car. And after that, he develops sleep deprivation, a bit of PTSD, and he starts consuming alcohol. And alcohol leads to problems at work, and he starts making mistakes at work. He starts getting disciplined by his bosses, and that leads to another anxiety. And finally, he loses his job. He starts drinking more and more, and then develop depression. He already had PTSD. So his GP starts him on antidepressants. And after some time, soon after starting antidepressants, he develops psychosis. He shared some of his thoughts on Facebook with his friend. His friend called his brother, and he finally got admitted to hospital. But interestingly, he was treated for psychosis in hospital, and they failed to pick up his PTSD, which was the root cause of all the problems. And also he developed psychosis soon after starting antidepressants. So he was diagnosed as a bipolar. They stopped his antidepressant, treated him with antipsychotics, and then sent him back to his GP saying that you need to go and see a private psychiatrist. But Guy has already lost the job. And he said, yes, he didn't understand the health system, how complex it is. GP sent him gave him a referral to see a private psychiatrist. And when he makes an appointment, he comes to know he has to pay a gap, and he didn't have money. So the treatment didn't proceed. So I was really surprised that the person has gone to hospital, treated by psychiatrist, but still not having treatment and not fully diagnosed. So I saw him after 3 years of all this happened, but he remained quite unwell. So the other example is how things after injury can lead to permanent impairment. So this guy is 60-year-old, very, very resilient person. And somehow he had a customer who was quite aggressive, may had some problem, and she stabs him over his nose. Anyway, he said, look, I have big shoulders. I will, so she, after stabbing, she started apologizing. And he said, look, no big deal. I understand people can have bad day, and I will let it go. But after that, this woman became quite difficult and started complaining about him, making things up, started saying that he assaulted her. So he had to go to police and make a complaint against her, that he did not assault her. So he saw a young constable who interviewed her. Everything went fine. But after that, a senior officer got involved who started investigating the case. He interviewed her, and she changed whole story. She just manipulated this officer. And he came back to him saying that, look, I can't find any evidence to charge her. I can't proceed. You need to sign this piece of paper, and that is it. So he also didn't want to go further, and he just signed the paper. And soon after he signs the paper, the police officer tells him, now I have evidence that you have assaulted her. And that really infuriated him. And he did not know what to do. He had to go to a lawyer. Lawyer has to complain to police conduct and commission. There was investigation. Then police offered an apology. But the whole process, he really developed severe anxiety, depression, stopped going out, and led to another problem. And he kept telling me that all he needed was an apology, and nothing, this all would have happened. So these kind of factors can complicate the picture. So when you are dealing with these claims, you are looking for the impact of the accident or impact of that work incident. But we do not realize that there are other factors which are playing in background, which can add to the problem. I've seen a couple of people with a late treatment. I saw this woman who had accident, very, very resilient South African woman who was working in a grocery store. She was also an accountant. And she saw 3 psychologists over 3 years. And finally, the last psychologist started doing EMDR, which was the treatment she required. But because she didn't get treatment for 3 years, it is going to be difficult for her to recover because the treatment was very, very late. And I've also seen some very, very resilient individuals, just like this person I talked in the third case, post-trauma complicating factors. This guy was so resilient. He did not tell his GP that he was having anxiety, and his GP provided him a lot of counseling, and but never referred him to mental health, which would have helped him to recover. But because he was very resilient, nobody figured it out that he has developed anxiety symptoms. All right, so I've just divided these challenges into 3 main things: challenges in determining causation, challenges in determining maximum medical improvement, and challenges in determining permanent impairment assessment, or PIRS. So let's look at the causation. So in terms of when you're determining causation, pre-existing conditions play a big role. A lot of clients who have pre-existing vulnerabilities, they develop major psychiatric problems. It doesn't mean that people who do not have vulnerability, they do not develop problems. They also develop problems. But if you see a minor incident leading to a big problem, most likely the person has pre-existing condition which has led to this problem. And then you look at the nature and severity of symptoms in causation. So we have PTSD, luckily, where we can very clearly establish causation, because PTSD is a specific disorder which happens due to a specific kind of trauma, and people develop specific symptoms. But same is not true for all other mental conditions like depression, panic disorder, agoraphobia, obsessive compulsive disorder. All these disorders can happen due to multiple factors, and each factor can lead to multiple kind of different psychotic symptoms. So it is very difficult to establish causation when you have situation like this. So we are going to talk about how to untangle that and how to work it out later on. But right now, I'm just highlighting the problems. And then there could be confounding or comorbid factors, like we discussed before, that other factors can also add up to the psychotic symptoms. So the other challenge which I faced is maximum medical improvement. And this is still a nightmare for me. So maximum medical improvement is basically when person has taken the adequate improvement, and we can say, well, this condition is not going to improve anymore. And then we can say this is a permanent impairment. We can do PIS rating and compensate that person. But there's a huge problems in determining who has attained maximum medical improvement and who has not attained maximum medical improvement. So the most common scenario is no treatment. And no treatment can happen due to the GP didn't offer the treatment. So I have seen some people who whose GPs are so busy, so it's difficult to get appointment with a regular GP. So nowadays GPs are doing share practice. So you just ring the clinic and anybody will see you. So then they end up in seeing different GPs, or their own GPs not able to offer the appointment. And sometimes the patients themselves are quite embarrassed about their condition. They do not talk about it. Now, when I am seeing them for determining maximal improvement, and I know someone can improve if they are offered treatment, but their GP has not offered treatment, it becomes quite challenging for me, because I'm not a treating doctor who can say, look, go and have this treatment, you will get better. I have to be seeing the realistic situation that this person's GP has not offered treatment, and already there's 1 year, 2 years have gone. What is the chance of GP picking it up and sending this person for treatment? The second thing, which is very common, is a lot of people refuse to take treatment. They do not like psychiatric medications. They prefer natural treatment, or they had depression, anxiety in the past, and they had bad side effects, and now they're refusing treatment. So I mean, we do have 15 antidepressant nowadays, so it's not that they cannot be helped, but it is a matter of counseling them and helping them to understand this is a different situation. But the same dilemma, like who is supposed to do that, and if someone has not done it, then should I say, well, this is it, and we do the rating. The third situation is inadequate treatment. It is also very common because people often do not take medications regularly. They do not remember to take medications regularly. The psychologists sometimes are not giving appropriate therapies. So there are a whole lot of issues that can happen. Some of the psychologists have a particular way of doing appointment. They see people only once in fortnight, and sometimes that's not enough. So inadequate treatment is also very common, which can lead to maximum medical quite a lot of impairment. So the real question which I was talking about is how a small problem can lead to a permanent impairment. So it's not the problem itself. The problem was small. It could have been treated, but because of unavailability of treatment, person has developed a permanent impairment. The second challenge is also a natural or spontaneous remission. So a lot of psychiatric condition, they do remit spontaneously, even if you do not do any treatment. But the problem in determining maximum medical improvement is there is a very variable course. So for someone, depression may remit in 6 months, but for someone it may last 2 years. It also depends on a whole lot of their personal situation, other factors, their motivation, compensation claim itself can play the role. So it can be challenging. And then there's a lot of confounding factors, like we discussed in other case, which can also affect the treatment response. So coming to the challenges in doing PIRS rating. So the PIRS is a scale which is developed by Australia. It is not used anywhere else. It's not accepted. It is a better scale than what other countries use. However, it is not perfect. The training is given when people start doing IMEs. Someone wants to get into medical legal space. So the first thing they do, they go and do a PIRS rating course. But at the time when you do it, you really do not know much about the challenges you're going to face. And you do not ask all the questions. I believe the training itself is a problem. And that's why the people interpret PIRS rating classes very differently. And unfortunately, there's no retraining, or there's no sort of fixed period, like after 5 years, you have to train yourself again. So all that has led to quite sort of different opinions. So I'll give you an example of one class, which is travel, and which is relevant with motor vehicle accident. So in domain of travel, a lot of psychiatrists who do PIS assessment will ask claimant, okay, can you reach to the work? Can you take public transport? And as long as person is able to drive to work, because PIRS is more about work capacity. It is developed in relation to work cover claims. Then they say, well, there's no impairment. However, the person who had a motor vehicle accident, they usually hate driving. They find it very distressing to drive in busy traffic. I had a patient who had a job in city and was living somewhere towards Toowoomba, a bit far away from city, 40 kilometers. And he used to get so stressed just because of driving in busy traffic, and his PTSD will kick in, that he lost his job. He stopped working. So even though he was able to reach to his work and drive, it doesn't mean that he was not distressed, and he should not be given any impairment in travel. So these are the problems in PIRS rating scale, which we do. The other thing is the time difference in IMEs. So when different psychiatrists are doing PIRS rating, there's often quite a lot of difference, and person's mental state change, their functioning changes, and you can see a difference in the rating because of changes in functioning. Now you can say that that when the first person or first psychiatrist assessed, he should have presumed that impairment is permanent and impairment is not going to change. But it is very difficult to predict maximum medical improvement. And that's where we see these differences, because often we don't get it right. The third thing is bias. I'm really amazed to see how much bias is there in this field. I have seen reports done by psychiatrists where they have given almost zero impairment in work capacity to someone who is totally incapable, doesn't have any capacity to work. So bias is there, and it's not very, very common, but it does happen. People pick up their side, and they it's mostly unconscious bias that they ask questions in a way in which they want to write the report. Or so the other thing is the timings of the IME. So sometimes when you are seeing a client, something is happening in person's life at that particular time, and that will exacerbate the impairment at that particular time. And if you see same client after 6 months or 1 year, you might have a very different PIRS rating. Claimant factors play a big role. So in mental health, what we say, it's not the incident which leads to problems. It is how people interpret or how people see that problem. So I'll give you an example. I saw this guy who was a tradie. He went to a party with his friends, and they all were drinking. The party was on the first floor. He was standing in balcony, and the balustrade broke. He fell down, broke his spinal cord in the cervical region, developed quadriplegia, what means all the 4 limbs stopped working, and he was wheelchair bound. And he got 90% impairment in his physical capacity. And he was sent to me by his lawyers to see whether he has any psychiatric problems. So he had a girlfriend who stuck by him even after the accident, who was living with him. And he absolutely did not have any psychiatric problem. He got a lot of support from disability services. People were coming to give him shower, to feed him, to cook him. And he said, no, I'm happy. I have no problem. I have my routine. I got these people who help me. I have friends. And I interviewed his girlfriend as well, just to ask that, has he ever said that life is difficult or is there any problem? But absolutely nothing. He did not have any problems. So the resilience can change the clinical picture. You might see someone who had a minor problem, but that person may not be resilient and may panic, and problem may look very big. The other factor is exaggeration of impairment, which happens. So we are working with human beings, and human beings have brain. They are clever, they're smart, and it can happen. They can exaggerate the impairment or also downplay the impairment. I've seen many people who are very resilient, and they will say, no, I have no problems. And when you speak to their family members, then you realize, no, they are struggling and they do have problems. So I will just show you this clinical vignette just to show you how it works in real life. So there were 5 people in a car, and the car had accident. So Miss A, she has a stable personality, no history of mental illness. She recovers rapidly, but she avoided car travel for a short period of time, and she was fine. Mr. B was a very insecure, anxiety-prone man. He never adjusted to leaving his mother, and he develops panic attacks without any reason. Miss C, her mother suffered from agoraphobia when she was a child, so she developed some phobia of traveling in car. Mr. D, he became depressed, and he could not stop thinking about the accident. And Mr. E has a father and grandfather who have episodes of severe depression and hypomania. He remained well for a few weeks, but then suddenly became hypomanic. So you can see that 5 people in the same car, same accident, but 5 different psychopathologies. Right. So coming to exaggeration of symptoms, or some people call it malingering. So as I said, it happens, but it happens both ways. People can minimize the symptoms, people can exaggerate the symptoms, or people can be very genuine. So the malingering can happen unintentionally. So what it means is a lot of these people, they are doing it unconsciously. They are not lying, they're not making it up, but that's how they are feeling. That's how incapable they are feeling, even though they might not be that incapable. Sometimes it can happen intentionally. So people who are very smart, they know PIRS, or they've learned about it from internet, and they can exaggerate their impairment. So how do we go about it? We take the collateral information. We heavily rely on information from GP's notes, which are taken contemporarily, or other information, and we try to match whether it's matching or not. Sometimes that information is not available. So we do have some psychometric tests, which are designed specifically to pick up intentional exaggeration of symptoms. So these tests usually pick up people. So what these tests has some items which are unusual, and if people pick up those unusual symptoms, we know that person is intentionally making them up. And also these tests match the severity of symptoms with severity of symptom which most of people have. So they have a normative data of normal population. If someone has PTSD, what is the maximum severity they get? And people who are exhibiting symptoms, they usually go very, very severe. And that's how these tests pick them up. Malingering can be full. Full malingering means there is nothing, no impairment, and person is just making it up everything, which is very, very rare. I haven't seen anyone doing full malingering. Partial malingering is very common. People exaggerate. Compensation can also lead to symptoms. So unintentional symptoms, or unconsciously people can feel depressed or stressed. So how do we go about it? So the way we go about this, the first thing is most of our impairment rating scale do not have any weighting for symptoms. So you may have very, very severe symptoms, but it will not affect your impairment rating. And most of rating scales, they are based on functioning and your how you are living your life. So if you focus on person's behavior rather than how they're feeling and what they're saying, it takes away that exaggeration part. So you usually ask, can you walk me through your day? Can you tell me what time you wake up? What do you do next? And that gives you a pretty clear picture of person's day-to-day life. All right. So what is the research or science evidence we have to deal with these challenges? So most of the research we have is a quantitative research. So quantitative research means you pick up 1,000 people, you ask them questions, and you figure out, okay, 30% people said this, 40% people said this, and you work it out. This is the common thing. But unfortunately, that quantitative research does not inform you the person who is sitting in front of you is among those 30% or 40%. So basically, the quantitative research is pretty good for doing research and having a broad understanding, but it does not help you with a particular case. So what helps you with a particular case is more a qualitative research. So qualitative research is done about one case. So you do pre and post. So you see how this person was before and how this person has changed. So that gives you a better information. So in qualitative research, we also see the temporal relationship of the incident. So whether person has developed the psychiatric problem soon after the incident happened, so, or there was a big time gap. So that temporal relationship helps you to understand whether there is a causative link or not. And then you look at the symptoms. So whether the symptoms are making sense or not. So like in PTSD is very common, it's very easy because it's a very specific disorder. We usually know what kind of nightmares and so you can ask people in nightmares what they are seeing in nightmares. So they may have a domestic violence and pre-existing PTSD, and they're not seeing the accident, but they're seeing something else. And that's how you can work out whether there's a causative link or not. And the third thing which really helps you is seeing the exaggeration of symptoms whenever there is a reminder of the trauma. So I saw this young girl who was sexually abused, but moved on in her life, was doing fine. working, and then she receives a letter from victims of crime that acknowledging her trauma and offering her help. And then suddenly everything started coming, and then she goes to, she files the claims and she comes for compensation, and suddenly you can see all the symptoms of PTSD, and she has decompensated. So that kind of exaggeration clearly proves the causation, and you can see in people whether symptoms are going up with the reminders of trauma or not. So solutions to all these problems is, as I said, pre and post. So you see how this person was functioning, and incident happens, and how person changed. That sort of clearly gives you an idea of the causation. And then I said that behavior versus subjective report. So you do not rely on what person is saying. You look into their behavior. People can say, I'm feeling very depressed. And then you ask them, okay, what did you do last week? And they say, oh, I went to movie and I had a good time. Then you know, okay, they're not suffering from depression. And the third thing is detailed explanation. So as I said, in mental health, it is not the thing which happens leads to the problem. It's how that person has interpreted that incident. So if you listen to people's interpretation and how they are reacting to that incident, that helps you to understand whether these conditions are linked or not. Then you also look into the internal consistency. So you ask the same question, different point of time in your assessment, and you say that whether person is consistent in their answers or not. You also see into continuity, and we usually ask the open-ended question. Okay, tell me about what happened, or tell me about how it affected you. And if person is able to give a continuous history without any gaps, it's probably reliable information you are getting. Collateral information is probably the most important thing, and this is the most neglected thing as well. A lot of people fail to get collateral notes and provide that information. So we have to rely on whatever person is saying. You can also look into validity, like face validity, whether what person is saying makes sense on face value. So if somebody is had a car accident and they are talking about driving difficulties, it has a face validity, right? You can see the content validity. So there are certain situations, or in certain situations people start feeling like that. There are certain disorders like PTSD happens in certain conditions. So that's what we call as content validity. And last one is construct validity. So you can't have a symptom of psychosis in PTSD. So every disorder has a construct, a syndrome, or a set of the symptoms. So you see whether a person is fitting into that construct or not. So if you're dealing with the bias, then I'm talking about if somebody has done a bias report. So you look into the report and you see whether a person has asked for trauma symptoms or not. As I say, that doesn't happen very common, but it does happen. I saw this report where the psychiatrist, after completing the assessment, asked claimant, do you have any other symptom? And patient said, yes, I have some nightmares and flashbacks. And psychiatrist did not explore that and concluded no PTSD because there was no avoidance of driving. So you look at that whether the other person has asked trauma symptoms or not. The most common reason for bias, in my experience, is the trust. So if, as an assessor, you do not have trust in the person you are assessing, is very likely you're going to have a biased assessment. So when you're doing assessment, you really need to trust, and you can decide it later on whether you whether the person is exaggerating or not. But at the time of assessment, you do not want trust to affect your assessment. So you really need to trust and listen and explore everything what person is saying if you want to have an unbiased assessment. Time is another issue. It takes time for people to trust you, to open up, to understand what you are trying to assess. It's you cannot do it in hurry. You need to have adequate time. Specific questions. So this is for lawyers. So often, if you do not ask a question, the psychiatrist will try to avoid answering, because as I said, this is a very gray area, and we try to take middle path or avoid answering whatever we can't. We don't need to. But if you ask a specific question, do you think in future this person is going to have problem with interacting with his work colleagues? Then psychiatrists will be forced to answer yes, they will have problem because of their irritability. They may not communicate well. But if you do not ask that question, you may not get that impairment. So when you are sending people for IME, they often get very worried, anxious. I have many people who told me they didn't sleep before coming to see me, because they are worried about whether their story will be accepted or not, or what kind of questions will be asked, or how they are going to perform, or whether because they all have anxiety, and the anxiety exacerbate, and that's worry them, whether they're going to have an anxiety attack. But most common thing which worries people is whether they're going to be believed or not. So if you tell them it is not an investigation, it's just an assessment of what is going on, and it's not a that you will be asked or you will not be believed. So that sometimes helps. And also, it is okay to tell claimants that they don't need to talk about things which they are uncomfortable. A lot of people have sexual abuse and other things in their life, and they worry that they have to disclose that. So that's something which we can handle, and we know how to get around that. But at outset, I tell people, if anything you're uncomfortable, you don't want to share with me, that is fine, but let me know what you don't want to share, so that I can decide whether to explore that or not, or how much I need to know. Sometimes people can have anxiety attack during the assessment, so ask them to bring their medications if they're taking. Having anxiety attack during the assessment can really affect assessment. The only way to do that is just you to do another assessment. People can bring their support person. It is not a problem if they want to have support person. And it's actually helpful if they can bring someone who can give a collateral information. So you get an additional information about their functioning. So whoever knows them best, if they can bring that person, that is helpful. Being punctual is very, very important, because psychiatric examination can go very long and they need to have extra time. So I have done some IMEs on video where a person after half an hour told me, oh, they have physio appointment, they have to go. So tell them that they need extra time. And also tell them to be truthful, because some people feel that they have to be really impaired in everything, which is not true. People can have good functioning in some areas, and in some areas they may not have good functioning. So they just need to be truthful about themselves. And also they need to dress as they usually do. I've seen people who just shaved and have haircut and everything after 3 months just to come and see me. And that really didn't help with the assessment. So this is for lawyers, that in compensation in mental health, psychiatric diagnosis does not play much role. It is about impaired functioning. So if your claimant is not functioning well, we can find a diagnosis. It's very easy to find a diagnosis. But if your person has diagnosis and symptoms, but they are functioning well, they are resilient individual, then it's very likely we are not going to find much impairment on PIS rating. The second thing is the brief, the documents and preparation of client is crucial in psychiatric IME. If you have prepared your client well, if you provided all the information, it's very likely you're going to get a very good, reliable report. Collateral history, as I said, is very important due to people having unintentional exaggeration of symptoms. And we talked about maximum medical improvement. That's something which I often struggle. People sometimes send me for PIS rating when someone has started a new treatment. And when someone has started a new treatment, I cannot say that person is at maximum medical improvement because I do not know how much that particular treatment is going to improve their psychiatric condition. So please do not send anyone for IME when they have started a new treatment. If someone has did not have any treatment, that is not a problem. But at the time of assessment, they should not start a new treatment. That's all I had to say. Thank you very much for listening. And I'm happy.
Thank you so much, Doctor. That was really informative, well-paced and well put out. In fact, we've had someone put a comment there that was extremely helpful to my role in insurance. Thank you. Does anyone have a question that they would like to ask of Dr. Garg? Okay, I have a question from someone who was unable to attend, and that question is that over the last 5 years, there appear to have been changes in the way that PTSD is being assessed and managed, and that in the past, the consideration was that a PTSD diagnosis meant the person would never work again and were pretty much permanently impaired. However, there seems to be evidence that a recognition that if a person can be removed from the triggered environment, that PTSD can be stable or resolved. What would be your comment on that?
Yeah, so the first part of question, yes, there have been a lot of changes in PTSD. So in the past, we believed that it only happens due to very major trauma. But now we are realizing, no, it can happen due to even just listening about the incident. So the person was not involved in this incident, but their loved one were involved in the incident, and they're just hearing about the accident. Even that can lead to PTSD. So there have been a lot of changes in assessment of PTSD. In terms of treatment, treatment has also become very, very advanced. We have much better understanding of PTSD. We have much better treatment of PTSD. EMDR is probably the best treatment at present. And it's not the EMDR per se, which is very good, but it's the EMDR training. The people who get trained in EMDR, they get trained very well in treating trauma. So that's why EMDR is getting more success than other trauma therapies.
Fantastic.
So, yeah, and the last part was that if person is removed from triggered environment, whether person can survive. So you need to think about PTSD is a phobia. It is a phobia of a particular sort of, if somebody has a motor vehicle accident, it's phobia of driving. So other than that phobia, usually people do well in other parts. So if they are working from home, they can function fine. So PTSD is affects very specific area of functioning. So if you remove the triggers and all that, yes, definitely the PTSD will settle. But just saying broadly that if you remove the trigger, person will function, that's not true, because there are a number of other factors play into the person's resilience, the other things happening in life. So the real outcome depends on person's resilience and motivation and the treatment they have. So it's a bit variable, I will say.
All right, we've got to finish up. I'm conscious of that, unfortunately. Very quickly, is it appropriate for a GP to diagnose PTSD following a motor vehicle accident?
Yes, absolutely. If they have a knowledge of PTSD and they can match the criteria, they can diagnose PTSD.
Great. Next one. In a Class 5 rating for the PERS category of employability, indicative that the claimant will never be able to work again, if the claimant has a chance of returning to work in the future, is a Class 5 rating inappropriate?
No, it is not appropriate. So the PIRS rating in Class 5 only tells you the impairment. It does not translate into person will not be able to work. We are living in modern world where there's a lot of advancement in technology. So people can have impairment, but they may not be disabled. So if somebody is not able to drive, they can work from home. So the disablement, whether they will be able to work or not, that has to be decided by an occupational therapist or vocational counselor to see whether there's anything which can compensate for the impairment or not.
Lovely. Thank you so much, Dr. Garg, for what has been a tremendous seminar. I've really enjoyed it myself. I've learned a lot. There's more comments in the chat from people thanking you for this seminar. Everybody, the recording for this will be sent to you sometime this afternoon. Thank you so much for attending. We look forward to seeing you at future seminars. Thank you again, Dr. Garg, and have a great day, everybody.
Thank you.